To summarize this chapter, rheumatic fever, which is caused by streptococcal bacteria, is by far the most common cause for mitral stenosis. It results in inflow obstruction and thereby in LA pressure overload. The prognosis is poor once symptoms have occurred. The typical features you will find in the echocardiogram are doming of the anterior leaflet, thickening, usually most prominent at the leaflet tips, commissural effusion, and involvement of the subvalvular apparatus. Other findings include left atrial enlargement, aortic regurgitation because we also have aortic involvement in rheumatic heart disease, concomitant mitral regurgitation, tricuspid regurgitation, and pulmonary hypertension. The valve morphology is important for the indication for valvulopathy. We quantify the degree of mitral stenosis based on visual assessment, planimetry. However, you need good image quality and you have to be sure that you align the 2D image exactly to the smallest orifice area. Transmitral gradients, especially the mean gradient. However, beware that this gradient is very strongly influenced by cardiac output. And pressure half-time, which is unreliable after valvulopathy, cannot be used in the setting of diastolic dysfunction, and has to be applied with caution in the presence of aortic regurgitation. When you quantify mitral stenosis, use an integrative approach and also look for other findings which include mitral regurgitation, tricuspid regurgitation, systolic pulmonary artery pressure, and the presence of thrombi, which are very frequently found in patients with mitral stenosis. To determine if a patient is a candidate for a valvulopathy, you use the so-called Wilkins score, which takes into account the thickening of the valve, its calcification, subvalvular involvement, and the mobility of the anterior leaflet. Things to look out for after the procedure are mitral regurgitation, TR, systolic pulmonary artery pressure, and iatrogenic atrial septal defects.